and Dr. Dhalapathy will be talking about when should you consider minimally invasive thyroid surgery.
Good morning, one and all. It's a privilege to be giving a lecture again in Trendo. My topic today would be when should we consider minimally invasive thyroid surgery. Actually, it's a very new one. Before we go to the topic per se, I'd like to bring about a few historical facts where in 1866, Samuel D. Gross, he described thyroid surgery as a horrid butchery, and he even went ahead to say that no honest and sensible surgeon would ever engage in thyroid surgery. That was the thing which was told about it. Then came this man who is considered as the father of modern thyroid surgery, Trendo2017, who had been awarded Nobel Prize for his revolutionized in thyroid surgery. He brought down the mortality from thyroid surgery from 50% to 0.5% in 1886. So at that time, till today it holds good, the mortality and the morbidity which Cocker revolutionized. And Halchuk even described, he's a student of him, he described the extirpation of thyroid gland typifies perhaps better than any operation the supreme triumph of the surgeon's art. That's how the surgery of thyroid is being described by none other than Halchuk. So, since the advent of endoscopic procedures for cholecystectomy, all endoscopic procedures have become the standard of care. So, the way of accessing the thyroid proved to be endoscopic at best, but certainly it's not minimally invasive. It's maximally invasive rather than minimally invasive. Maybe the scar is not visible because we are not going through the normal anatomical planes as we do in for laparoscopic procedures where we have a normal plane as well as cavity is there. Here we go violate the normal anatomical planes and it's a maximally invasive one, though we call it as a minimally invasive one. It's a misnomer basically. So, to have a surgical procedure, it must be anatomically and biologically sound one, and it has to be reproducible. That's the very important thing. Not a single person. It has to be taught and it has to be reproduced with the least complications. And it must also have a short learning curve so that it can be reproduced by others. And it must be easy to learn, teach and practice, and it must be cost effective because at the end of the day, cost does matter. And it must give good cosmetic and functional results. So when we talk about minimally invasive thyroidectomy, the one thing which stands out is cosmesis. That will be the thing that will differentiate between other normal standard classical thyroid procedures. So the fact that a new technique is available does not necessarily mean its implementation is appropriate. So we need to individualize and customize to our patients. So when we talk about minimally invasive thyroidectomy, it can be broadly classified as even an open procedure when it is less than 6 cm is otherwise called minimally invasive or mini incision thyroidectomy. So it can be open procedure when it is less than 6 cm is considered as minimally invasive. It can be endoscopic assisted or truly endoscopic, or it can be used done with a robot. So when we call about true endoscopic procedures, there are various routes to approach the thyroid gland, especially through the axillary route, breast route, or both axillary and breast as well as latest transoral route. So, what revolutionized this minimally invasive approach? There are new gadgets that has helped in revolutionizing these minimally invasive procedures, like this harmonic scalpel, which has a aesthetic as well as sense like just we use a artery forceps where we can use this harmonic focus for dissection, ease of dissection as well as coagulation. So this one and the ligature is both revolutionized because of better hemostatic abilities. So minimally invasive open surgery, we go with the mini incision. The incision is less than 6 cm. You can use even a lateral incision if you are planning for a hemithyroidectomy. Use a latest gadget like harmonic scalpel or ligature. Even it can be done under local or regional anesthesia. The main thing is day care procedures, that is less than 24-hour discharge. So majority of these procedures have been done, especially if you take in US for proven or suspected malignancy, because for clear benign nodules or clear cut class 1 or class 2 let us now we don't go for surgery. So in these minimally invasive procedures, the thing is we are not able to see the paratracheal and pretracheal nodes for the evaluation. That's the thing, because we'll be able to directly visualize the thyroid and do a thyroidectomy, and if you are suspecting malignancy or in malignancy, the evaluation of this node becomes difficult. And 20% of these thyroid cancers have extrathyroidal extension, which might require the exposure is inadequate in these settings. And moreover, ultrasound, when they have bilateral thyroid nodules, might require total thyroidectomy, where we need to go both ways. Suppose we are going by axillary route as well as the breast route, then we have to go bilateral axillary and breast approach. So the classification of thyroid surgery, this is open surgery. That is type 1 is, the length is 0 to 2 centimeter, it's type 1. This can be done for nodules less than 2.5 centimeter. And the thing is, they must not have associated thyroiditis, because thyroiditis make the dissection on the plane very difficult, and it's not so easy to dissect in a thyroiditis patient, even in open surgery. So in case of endoscopic or these minimally invasive route, it becomes more difficult. In type 2, it is for the incision length will be between 2.1 to 4 centimeter. The nodules criteria will be less than 4 centimeter. For type 3, it is for less than 6 centimeter nodules, and the incision is also 4 to 6 centimeter. So conventionally, if it's more than 6 centimeter, it is not considered as minimally invasive thyroid surgery. So these are various incisions for this minimally invasive thyroid surgery, where we use mini incision to retrieve the thyroid gland. So the advantages is, because of the smaller incision, we have better cosmesis, the pain is also less, faster recovery and earlier discharge. But in cosmetic terms, the quality of scar is more important than the actual length. So if you put a scar over the skin crease, whether it is a 4 centimeter or 6 centimeter or even 10 centimeter, doesn't matter, because over 3 to 6 months, we will not be able to find the scar if it is in the skin crease. So the quality of scar is more important than the actual length of the scar. That's actually to be considered. And minimal incision, the disadvantage is it may cause excessive skin stretching, bruising, and forcible retraction might be needed. So the pain might also be greater than a normal conventional procedure because of the excessive stretching, and it may cause inadvertent cauterization of the skin edges also. That has to also be kept in mind when we are using a mini incision. So then came the endoscopic assisted procedures, where we combine both mini incision as well as endoscopic assisted. This was popularized by Micodi way back in 1999. He's an Italian, where he used, without gas, he used this minimally invasive procedure, where he used to lift the skin and use these endoscopic procedures, where he used 1.5 centimeter skin incision. So for that, the criteria, the nodule has to be less than 3.5 centimeter, and volume of the nodular gland is less than 25 ml. Mostly it is done for benign diseases and very low risk PTCs. So the absolute contraindication for this is large goiters cannot be approached by this thing, and previous neck surgery definitely is a deterrent for these minimally invasive procedures. As I said, the thyroiditis and suspicious of lymph nodes are locally advanced malignancy. All these are absolute indications. When we come out relative indications, previous neck radiation, Graves' disease, because of the excess vascularity it can cause. So through a small incision or a root, it will be very difficult if there is excessive bleeding, and the visualization of these nerves and parathyroids will become more cumbersome. So moreover, short neck in obese patients is also a great difficulty. So endoscopic surgery, as we say, though it is a minimally invasive surgery, it's a maximally expensive surgery compared to a normal conventional surgery. This also has to be kept in mind. And not only minimally invasive, it's maximally invasive basically. Though the incision is small and we go through various routes from transoral, axillary, breast, all those things. So this is a picture for a neck approach, where instead of a 4 or 6 centimeter incision, where we use lateral ports with insufflation. And this is for a subclavicular anterior chest approach, where we, in the center we use a 10 to 12 millimeter port and lateral 2 ports, and we access the thyroid gland for one side. Suppose we want to operate for the right side, then we have to again make these ports on the right side. So we are violating the normal anatomical planes in these patients. So in axillary approach for the right side nodule, we go through the right axilla, where we use usually 3 ports. And this is bilateral axillary breast approach. For a right side nodule, we use a camera port, both the breast in the nipple areolar complex and the right side axilla. So for the left side, instead of the right axillary port, we use the left axilla. So we need 3 ports in the so the time, the learning curve is also more, and we need to violate all the chest wall planes to access this one. So this is the axillary breast approach, where right side we go, and there are size criteria for these nodules also. Moreover, we need to individualize all these to a patient. So transoral thyroidectomy is coming in a big way. Actually, a person called Angwon, he is in Bangkok. He travels all around the world with this transoral thyroidectomy. Actually, we were fortunate. We went there for 1 week there. We did observe his procedures, and he does search for nodules even for 10 centimeters. When he was operating for a 9 centimeter thyroid nodule through a transoral route. But the thing is, he modulates before delivering the gland. And ultrasound volume up to 45 ml he does through transoral route. And benign tumor only he does. And Bethesda 3-4 category maybe. And papillary microcarcinoma he is just started doing. But if he clear-cut malignancy, he doesn't venture with the transoral route. So this was the thing where he used a 10 millimeter sublingual incision and 2 lateral ports. Through this direct approach, we have a special instrument for creating a plane and take a bite over the strap muscles, lift it up, then first here they clamp the superior pole, then medialize the lobe, see the nerve, parathread, and retrieve it in a endobag after modulation. But there are various complications associated with this, though it looks rosy to do a transoral thyroidectomy, the infection, and so much of bruising over the area just above the thyroid gland. All these things does happen in transoral route. So to summarize or compare the MIT with the axillary breast approach or bilateral axillary breast approach, if we see the trauma of access is very minimal in case of open minimally invasive thyroidectomy, and the specimen retrieval is good. So we give the whole specimen to the pathologist for clear-cut histological examination. The cosmos is moderate, and if we can use a skin crease incision, maybe by 6 months we will not be able to see the scar. American cases, yes, it is definitely the standard of care, the minimum open approach. Axillary breast approach, trauma of access is high because we are violating the planes. We need to cut or modulate the tumor before we retrieve it. Cosmosis is good because we don't have a scar in the neck, but we do have scar in the axilla or in the breast area. It is indicated for tumor less than 3 centimeter. For BABA, that is bilateral axillary breast approach, the trauma of access is very high. And here also we need to modulate the tumor, and the cosmosis is good in the neck, and malignant cases also tumor less than 3 centimeter. This transoral thyroidectomy, trauma of access is high. Here also we need mincing. Cosmos is very good because we don't even, this is truly scarless compared to axillary or axillary breast approach where we have scar elsewhere. In transoral thyroidectomy, we don't have any scar in the skin at all. But for malignancy, it's a doubtful one. So to conclude, good judgment comes from experience, but to get that experience comes from bad judgment. So the saying by Mayo in 1910, the best interest of the patient is only interest to be considered. So we need to individualize all these various procedures, and thank you for your patient listening.
Thank you, Dr. Dhalapathy. Any questions?
What is the role of drains in minimally invasive thyroid surgery?
Actually, in case of axillary procedures or this BABA, this bilateral axillary procedures, the drain has to be kept because they are violating the plane. Lot of tissue dissection will be there. The drain sometimes it has to be kept for even 1 or 2 weeks also. In case of transoral thyroidectomy, they don't keep a drain. they just keep a compressive bandage. But in case of this axillary and breast approach, definitely drain is a must. In case of open surgeries, either we can keep or we can get away with the drain. But axillary procedures, definitely drain, and consistent seroma discharge is a major complication or thing that has to be kept in mind when we are dealing with the axillary or a breast approach.
What about perithyroid hemorrhage immediately after surgery?
In which one?
Minimally invasive. Perithyroid, just around the thyroid, which you have removed, there could be bleeding. What do? Do you open up?
In which procedure?
Minimally invasive thyroid surgery.
Minimally invasive, which group?
Laparoscopic.
Yeah. That's what we keep a drain, sir. In case of axillary and breast approach, for this bleeding, we keep a drain. In case of transoral, because of the constraint of space, we don't keep a drain. In that case, we put a good compression for at least it has to be kept for 24 to 48 hours, so that we hope that no bleeding.
What is the incidence of reoperation after complications of minimally invasive? Incidence
In which
of re-surgery immediately after minimally invasive thyroid surgery, what is the incidence?
reoperation.
Yes.
That also depends on the way of access you are doing, whether you are doing an axillary procedure or both combined axillary or breast or transoral. It varies from center to center and depends on the individual surgeon.
There must be some studies which talk about the incidence. Do you have any figures?
Yeah, it's around 2 to 5%. This re-surgeries, especially in the earlier phase, because it does have a learning curve for each center. So, as the surgeon gets more experience in it, the complication rate is less. So, these are early days for these transoral thyroidectomies, and maybe they use rope in Korea, or they use robo for this transaxillary and breast approach, where now they claim the complication rate as equal as an open procedure, even the re-surgeries or whatever it is.
What is the incidence of recurrent laryngeal nerve damage?
Actually, ideally it has to be less than 1%. That's what is a good thyroid surgeon or a good volume thyroid center. Less than 1%.
But
If it is more than that, definitely it has to be reconsidered.
yeah, but is it less than 1% in minimally invasive thyroid surgery?
Most of the series, after maybe in axillary procedures, they do claim the incidence of recurrent damage is around 1%. Even in this transoral thyroidectomy, the person who does claims to be around 1% only.
Yeah, there are any randomized studies to prove this?
Randomized
Control studies.
Randomized control studies, actually only we can compare these procedures with the standard open procedures. Yes, that's what, sir. It differs between centers and the individualized surgeons, because the surgical skill differs between every person. So because the transoral thyroidectomies, all these are in a very infant stage. So it does take time to really have to recommend this is the standard of care. Just like a laparoscopic cholecystectomy, where now it has really fully replaced open cholecystectomy. It's not these endoscopic or minimally invasive procedures standard of care, unlike classical thyroidectomy. Still, classical thyroidectomy is the standard of care. All these are new venture because, as we say, again I am telling, it's not in the natural brain as in the abdomen.
Thank you, doctor.
What is the total duration hours comparing the total thyroidectomy versus minimally invasive when doing the high qualified or high volume surgeon performing the surgery?
Definitely it has a steep learning curve in these endoscopic procedures. The gadgets we use very expensive, and suppose we are total thyroidectomy, we can perform in 1.5 hours maybe, or maybe 2 hours at the maximum. Here it does definitely take 3 to 4 hours at the initial phase. So all these things, theatre cost, everything does matter. Rather than the gadget, all those things, theatre timing, all your thing does matters, and it's expensive. That's a rare possibilities there. If we are actually not in the right plane, if we go directly into the mediation, the possibility is still there because we are insufflating the gas also. We keep the pressure around 16 to 20 millimeter. Yeah. Theoretically, yes, but that also depends on the expertise of the surgeon.
What's the conversion rate over surgery?
That becomes
By doing surgery, conversion rate is very invasive surgery.
initial phases, yes sir, the conversion rate is very high. As you become more experienced, the conversion rate does go. Just like in all other laparoscopic procedures, this also has a learning curve.
Thank you, Dr. Dhalapathy.